Hello everyone, welcome to this lecture. Epidemiology. Epi, among, demo is people, logy is study. So epidemiology is a study of occurrence and distribution of health related events, states and processes in specified population, including the study of determinants affecting such processes and the application of this knowledge for the prevention and control of relevant health problems. So occurrence keyword, distribution keyword, determinants keyword, these three keywords we obtained from the definition. So these are the main components of epidemiology. So studies of disease occurrence, studies of disease distribution, studies of disease determinants. Okay, disease occurrence is measured by morbidity and mortality in scales of rate, ratio and proportion. What is rate? Numerator is a part of denominator. Multiplier will be 1000, 10,000, 1 lakh. Now ratio. Numerator is not a part of denominator. Proportion. Numerator is a part of denominator and the multiplier is 100. Now studies of disease distribution is measured by descriptive epidemiology, and studies of disease determinants like risk factor and all, these are identified by analytical epidemiology. Aim of epidemiology is to describe the magnitude and distribution of the disease, to identify the etiological factors also called risk factors. Third one, to provide data for planning, implementation and evaluation of preventive, control and therapeutic measures. Epidemiology versus clinical medicine. Epidemiology unit is a population, clinical medicine unit is individual patient. So here doctor goes to the community, here patient comes to the doctor. The main concern here is pattern of the disease in the community. Clinical medicine main concern is individual patient's disease. Here subject is conceptual, graphs, tables and all. It's complex little. Clinical medicine easily perceive for this disease, this treatment, this diagnosis. And uses of epidemiology to study the historical rise and fall of the disease. For past 50 years, communicable diseases are coming down, non-communicable diseases are rising. So to study the historical rise and fall of the disease used, and community diagnosis. In the particular community, what are the diseases are prevalent, to identify and quantify how much it is, and then planning. In some of the countries, hospitals are unnecessarily built and then equipments are obtained without knowledge of a particular disease in the community. So if we know the disease problem in the particular community, we can allocate the resources according to the need of that community. For example, tertiary hospital is needed or not, or particular screening program is necessary or not. Evaluations. So after the application of some health measures, to evaluate whether it is functioning well or not, we need this evaluation. For example, to evaluate the outcome of the vaccine, we will be using evaluation. And evaluation of individual risk and chances. Relative risk or odds ratio can be calculated getting this particular disease. If family history is there, how much chance is there to develop that particular disease. Now syndromic identification. About 3000 plus syndromes are described, but particular defect is unknown. Only 20% of these are identified. So to define and redefine these syndromes, epidemiological studies are very much important. Then complete natural history of the disease, to study the broader perspective of the disease, to find out the gaps in the natural history of disease, to study about the age and host environment, we need epidemiological studies. And searching for cause and risk factors. So this disease is caused by what? For example, rubella causes congenital effect in newborns. Thalidomide is a teratogenic drug. Smoking causes lung cancer. So to identify the risk factors, epidemiological studies are needed. First component, studies of disease occurrence measured by morbidity and mortality. Morbidity is any departure, subjective or objective, from the state of well-being, that is morbidity. There are three aspects in the morbidity. Frequency. Disease frequency is measured by incidence, prevalence and notification rate. Duration of the morbidity, duration of illness, duration of hospital stay and sickness spells. How many times in a particular year he got ill. And severity we have disability rate, case fatality rate and readmission rate. In detail, incidence rate, this is number of new cases in that time period divided by number of people are at the risk during that period, multiplier is 1000. Attack rate, again number of new cases very limited period of time divided by number of people at risk during that time into multiplier is 100. This incidence specified period of time, so it's a long period from here to here, so it's a limited period of time. Multiplier 1000, multiplier here is 100. And secondary attack rate, number of exposed people develop disease within that particular incubation period is called secondary attack rate. Multiplier is 100. Prevalence, we have point prevalence, period prevalence. Point prevalence is number of all cases, new and old, at a given point of time divided by number of people at risk at same period into 100. For instance, always multiplier is 1000, prevalence 100. Now period prevalence. Period is number of cases old and new for a period of time. This period to this period, how many cases new and old, divided by number of people at risk into 100. This line, vertical line, is from January 1 to December 31st. So this one is the first case started before January and continuing even after December 31st. Second case started before Jan and ended after Jan. Third case started before December and ended after December. And another case is here, the case 5, case 6, case 7, case 8. Now what is incidence rate? Only new cases. So incidence rate from January to December means only a new case from January to December. Can we take one? No, because it happened before January. It's only new case. Whatever disease happened after January will be taking. So second also we can't take. Third, yes, we can take. And fourth, yes. Fifth also yes. Sixth, no. That is after December. And 7 also no. 8 we can take. So our incidence will be 3, 4, 5, 8. Now point prevalence. For January 1 will be new case and old case. So number 1 yes, number 2 yes, and 7. This 3 will be point prevalence of January 1. Now take point prevalence of December 31st. 1 yeah, 3 yeah, 5 yeah, 8. Now period prevalence of January to December. First one is not a new case, not starting after January, but it is continuing in January, no? So that's a old case. We should add 1, we should add 2, we should add 3, we should add 4, we should add 5, we should not add 6 because within this period. And we should add 7, we should add 8. So this will be the period prevalence. Now what is the relationship between prevalence and incidence? The formula is prevalence is equal to incidence into duration. Prevalence increases in prolongation of life due to chronic disease and immigration of the disease. Some disease people is going to come, so we will be getting more disease now. Now emigration of the healthy one. Some healthy population is going out of this community. Whoever is here is high, that means prevalence is high. Now when prevalence decreases, recovering very fast, a patient might have died. That is also one of the reasons for decreased prevalence. And then preventive program will prevent the new disease from occurring. Immigration of healthy and emigration of disease. Uses of incidence. It represents the new case. Prevalence represents the old plus new case. To know the current disease load, we need incidence. For the monitoring and evaluation of the program, disease is lower in that population means that program is functioning very well. And then starting point for a theological study. If we know the current scenario, we can start the study. And prevalence tells the magnitude, overall magnitude of the disease. Before starting a program, to plan the program, we need the magnitude, overall disease in that community. So here we are using prevalence. And then study the chronic disease, measures of mortality. CDR is crude death rate. Crude is a total death rate. So total death divided by mid-year population. Mid-year population means this is suppose January to December, mid of the year, that is July 1st. July 1st they are going to count how many people are there in the particular country or a place. So that time how much is the population, that is mid-year population. So multiplier is 1000. And specific death rate, so it can be cause specific, it can be group specific, it can be period specific. First we'll divided by mid-year population of that cause specific or group specific or period specific into 1000. For example, number of death due to TB is 100 divided by total people is 1000, multiplier is 1000. This is specific death rate. Okay, now proportional mortality rate. TB death is 100, but in mid-year population, in total population into proportion is always percentage, no? Multiplier is 100, here multiplier is 1000. That is the difference. A specific death rate used to compare proportional mortality rate is, we can tell that out of 100 people, how many are died of TB, how many are died of leprosy, how many are died of CAD. Now survival rate, how many people survived or alive after 5 years of treatment, divided by number of people diagnosed or deceased into 100. Suppose 100 people are diagnosed as having the TB, out of which only 50 people are alive after 5 years of treatment. This will be the survival rate. Survival rate tells the prognosis of the disease, how long we can survive. And case fatality rate tells the severity of the disease. Suppose we have 100 TB patient diagnosed, out of that 20 people died. So among diagnosed, how many died is case fatality rate. Standardized or adjusted rate, here all the age group people are there, here also all the age group people are there. 60 plus people may be more in this group, less than 60 year people are more in this group. So here age is unevenly distributed. So standardization is the method used to adjust a variable which is distributed unevenly among two groups. Okay, now we have direct standardization, indirect standardization. This population A, this is population B. First one, calculate the age specific death rate for population A and B. Age specific death rate. Suppose take example of 1 to 5 years. Mid-year population for that age group is 4000 and death in that age group is 60. So age specific death rate will come 60 by 4000 into 1000. We get 15. So like that 15 to 14 year age is there. So we have, suppose take 4500 is the mid-year population of that age group. The death in that age is 20. So the formula 20 by 4500 into 1000. The answer we get is 4.4. Second step is choose the standard population. It can be national value. Same age group 1 to 5 year, 2400 people are there of that age group. 5 to 14 year standard population we have 9600 children. Now third step is expected death is equal to age specific death rate divided by 1000 into standard population. So age specific death rate we got is 15 divided by 1000 into standard population. So standard population of that age group is 2400. And age specific death rate for other one 4.4 divided by 1000 into standard population is 9600. So we get around 36, we get around here we get around 42.2. Next step is standardized death rate per thousand is equal to total expected death divided by total standard population. So total expected death, we are going to add this 36 plus 42, 78.2. So 78.2 divided by 12,000 into, we may get one answer. Suppose we got 6. This is of population A. We have to calculate same like this for population B. Age is standardized now. We can compare population A with population B. Now indirect standardization formula we have is standardized mortality ratio is equal to observed death divided by expected death into 100. If answer comes more than 100%, represent the unfavorable mortality experience. Uses of mortality indicators. Using, if we know about this much death happened in that place, we can give more resources to that particular area. And limitation of that mortality indicators: incomplete reporting, single cause of death, and changing the coding system. Now they might have changed the coding system, so the diagnosis may vary. Lack of uniformity, the reporting format of one group of people is that different, other people is different. Lack of accuracy, some people they don't enter the correct data only. So these are the limitations of mortality data. So we are at end of our lectures. So we have studied about epidemiology, three components of epidemiology. So we studied about occurrence of disease, in that measures of morbidity and measures of mortality. Hope you understood the lecture, and thank you for listening.